So that was, like I say, or like Catherine said, that was a focus on HSR in practice, and now we're going to move to a broader level and talk a little bit about policy. So I'm going to give a few examples around how health services research can interact with and inform policies around hospitals, and then we'll move into primary care. So the three kind of linked examples I'm going to talk about are all the same objective of improving hospital performance, but slightly different approaches. So how do we evaluate the effectiveness of service reconfigurations with a view to informing continuous improvement where required? Funding models, that's a really key area of policy with respect to hospital performance. And then finish with a little bit of a discussion around patient-reported outcomes or patient-reported outcome measures, which I'm sure everyone has heard a lot about, and we're really just waiting to see what impact they're going to have, if any. So the example I'm going to use for service reconfiguration evaluation is actually from England, but it's a really nice example of what you can do with health systems data to look at the impact of big changes in the provision of hospital services. So this was a natural experiment, really, in that there were decisions made to reconfigure the delivery of stroke services in two areas of England, so in Greater Manchester and in London at around the same time. So here we're describing the configuration prior on the left-hand side. So you have a stroke, you go to your local ED, you're then admitted to an acute stroke unit or even a non-stroke ward, and then following that you have rehab services in the community. And we can see the difference in the reconfiguration. So in Manchester, depending on when you present, so if you present in less than 4 hours of onset of symptoms, you get referred to a comprehensive stroke centre or a primary stroke centre. If you're over 4 hours, you go to a district stroke centre, receive the appropriate care at those locations, and then onto rehab. In London, everyone goes to a hyperacute stroke unit, and then maybe down transferred depending on diagnosis. But in terms of the evaluation, they use what was called a difference in differences approach, and these figures illustrate the effects of the different reconfigurations quite nicely. So you've got four outcomes, so mortality at different days, 3 days, 30 days, 90 days post-admission. And what these figures are showing are the change in those outcomes over time. So the blue line is the rest of England, so outside of Manchester and London. The red line is what happened in Manchester, and the green line is what happened in London. And for some reason, they've switched the colours for the time of reconfiguration. So the red vertical line is the timing of reconfiguration in Manchester, which links with the green vertical line, horizontal line, and the green is the London. And so you can see that over time, mortality was decreasing in the rest of England, and it continued to do so in London and Manchester. And as you kind of go out to 90 days, you can see the impact was increasing. Length of stay also was decreasing over time. So it really just emphasises the need for a control, because if you'd have just looked at Manchester and London on their own, you'd say, well, that's great, it's looking good. But because we can look at the rest of England at the same time, we can say, well, actually, there was a general improvement over time. So we need to control for that improvement over time. And so when you actually look at the statistics, compared to the rest of England, we can see that the reconfiguration in London resulted in a significant reduction in mortality at all of those time points. Whereas in Manchester, there was no impact on mortality compared to that background improvement in outcomes. Whereas for length of stay and costs, there were significant reductions at both locations. So that type of evaluation, just using health systems data, they didn't have to go out and collect any new data, provides real insight into the impact of those alternative reconfigurations. Looking at funding mechanisms next, activity-based funding is taking over the world, it seems. Certainly in Australia, with the Independent Hospital Pricing Authority controlling or implementing activity-based funding at a national level, it is now relevant in all states and territories. So the basic objective is that the hospitals receive funding for the activity that they produce, and that funding reflects the expected costs of delivering care. So the idea is that if you're delivering care at above expected costs, you've got an incentive to reduce costs because you're not, you're essentially losing money. But in terms of the evaluation of activity-based funding, there's been a reasonable amount of before and after type studies looking at the impact, and they find that we get increased activity because there's an incentive to do more because you're getting paid for every additional patient you treat. There's a reduced length of stay, which you'd also expect, and combined, there's a reduced rate of growth in hospital expenditure. But the big question really is, what's the effect on patient outcomes? So we've got this incentives to reduce costs, but what's happening with respect to outcomes? And that's really an area that's not been a whole lot of research on, but with the advent of linked data, we can now look at outcomes beyond discharge. So previously, we really had to focus on inpatient mortality, but now we can go beyond discharge and look at readmissions, or related readmissions and mortality in a time period beyond discharge. And so we looked in South Australia at chest pain patients. And so here we're looking at outcomes, mortality within 90 days and related admissions within 90 days. So we've defined our base case hospital, Hospital 1. We can see the proportions, so 1.2% of patients dying within 90 days. And then we've got the odds ratios compared to Hospital 1. So we can see Hospitals 2 and 4 have got a lower mortality than Hospital 1. Not statistically significant, so these are the confidence intervals. You can see they cross 1. But Hospital 3, maybe we want to look at in a bit more detail because they've got almost, more than double the mortality rate at 90 days, and that's statistically significant. So that provides an indicator of what we might look at as a consequence of hospital performance, but linking back to activity-based funding. And likewise with admissions, we can see here that all 3 of the hospitals have got increased rates of admissions compared to Hospital 1, but Hospital 4 in this case has got a statistically significant increase in admissions. So it's really giving us a bit more of an insight into potentially important outcomes that we can investigate further. And we certainly wouldn't recommend taking drastic actions based on these results, but it's really a kind of screen to say, well, which hospitals might we want to look at in a bit more detail. That was South Australia, where we've got relatively few hospitals to look at. This is just an indication of what's going on in New South Wales. So the Bureau of Health Information are doing a lot of really interesting work. And this is a nice way of presenting similar data. So it's looking at expected and observed mortality rates following admissions for stroke. And you can see that the dotted red line is the 95% confidence interval, upper confidence interval. So hospitals that are above that line, it's an indication that their mortality rate is significantly higher than would be expected for a hospital of their size. And below the green line is identifying hospitals that are really performing above expectations. So it's just another way of presenting similar data, but there's room for implementations. At this stage, we're really just illustrating these types of methods, but how they get used in practice is the next stage in this area of research. And then the third item I wanted to talk about was patient-reported outcomes, and this also relates to funding, because ultimately, and some people are certainly proposing this, that activity-based funding should account for patient-reported outcomes rather than just clinical outcomes. So patient-reported outcomes are where patients fill in surveys describing their quality of life or the symptoms associated with the condition that they're being treated for. And the best example of this, of the use of patient-reported outcome measures in the English NHS, where they've been collecting pre and post PROMS data for these 4 conditions. And this paper, published in 2014, they started in 2009, showed how things were progressing over time. So in the first 3 years of implementation, just taking hernia repair as an example, using the generic patient-reported outcome, we can see that there's exactly no difference in PROMS post-discharge across those 3 years. So that's a bit disappointing, because the idea is that by collecting the PROMS data, you're going to incentivize hospitals who are maybe getting worse patient-reported outcomes to improve their performance, and you'll see a general increase in PROMS over time. But that clearly wasn't the case. So a study in Ireland actually took it one step further and took direct action to feed back PROMS data to individual surgeons. So this was a randomized controlled trial of 21 orthopedic surgeons, half of whom received peer benchmarked feedback on the patient-reported outcome measures of their patients with some education. But again, no impact was identified. And I think there are some reasons for that in this particular trial. So there wasn't a huge amount of time provided for the surgeons to improve their performance based on the feedback of the PROMS. But also there wasn't much variation at baseline, or there wasn't a whole amount of detail in the paper, but it certainly implied that there was a similar range of PROMS scores across surgeons. So you just kind of wonder whether there was really much of an incentive to improve if there wasn't that much variation at baseline. So the evidence to date is not too promising in terms of the potential for patient-reported outcome measures to improve hospital performance. But I think it really just provides a foundation for looking harder for how PROMS should be used. So I think there's a bit of a feeling that PROMS is a good thing that we should be doing, but I think the evidence to date suggests that we really need to think and investigate methods for using PROMS to improve hospital performance. So it'd be interesting to see how that progresses in the coming years.